Okay, so can everybody see that now, or yeah, let just flag up if you can't. So hi, my name's Eve Cooper. I'm a team leader for Paediatric Physiotherapy and Occupational Therapy, and this workshop is based on our functional skill and motor coordination aspect of our service. Oh, sorry, there's a delay in slides. It should be on the bit about the service background now. So our service is a joint OT and physio service. And from an OT perspective, our service aims to support children with motor coordination and functional skill difficulties, both at home and at school. And this focuses on improving functional outcomes. So we're not part of a diagnostic pathway. We're about improving outcomes for the children. The example of some of the children that we see accessing our service are children who present as clumsy or who fall a lot, those who struggle with PE, so maybe with catching, throwing and general coordination, children who struggle to keep up with the demands of handwriting as they progress through school, those with fine motor difficulties, those with dressing difficulties such as organisation, fastening buttons, shoelaces, etc. Children who struggle with independent skills such as using cutlery to eat, and often children with sensory preferences which are impacting their ability to practice skills and develop those skills. So 3 years ago, we made changes to our service model delivery by adopting a graded approach and providing a tiered structure to our service. Prior to adopting this graded approach, we had a few issues, which is what prompted the graded approach change. So at that point, many referrals came with a focus on diagnosis rather than improving outcomes for children. And we think this is likely because of the perception that a diagnosis is required to gain further support, which obviously shouldn't be the case. We also found that the expectations of the service weren't clear, and parents in particular were often waiting for us to then give a diagnosis, which is not what our service is for. And we were seen as a bit of a gateway into community paediatrics because the waiting lists were quite huge. We also therefore had a long waiting list ourselves, and at times children were waiting for up to 12 months for an assessment. And so during that time, nothing from an OT perspective was being done to improve those outcomes. There was a long wait while not a lot was happening. So these issues weren't isolated to us alone. It was very much a common problem with paediatric OT services across the country. So the Royal College of OT recognised this, and they said, for services to meet growing societal demands, there needs to be more collaboration between health and social care, education and the voluntary sector, and a better balance of provision at universal, targeted and specialist level. So this is the targeted, the universal targeted and specialist intervention. So this is the tiered service model. So the universal interventions are of benefit to everybody. These provide opportunities for children to develop skills. The targeted interventions are for children who need a bit more support compared to their peers in order to reach their potential. And the specialist intervention is for those that require more personalised input from a skilled professional in order to meet their needs. And within our trust, it's not just the OT service that went to a tiered service model. We've recently had our speech and language team have switched over to this approach too. So the benefits of a tiered service model are early intervention. So children don't need to sit on our waiting list for 12 months prior to them getting the advice and support that they need. And it prevents escalation of problems by providing a timely input. Advice can also be applied directly into the child's home or education setting. And this repetitive and relevant skill practice within their everyday life is really what improves their outcome in skill development. And that's a really important point to remember with OT in particular, that there is no magic wand. It is all about practice and repetition, and it takes time and effort. The other benefits of a tiered service that it's open to everybody, it's inclusive to everybody, and it's accessible to all. So this slide is just to show how the graded approach supports our wider trust objectives. So not just the RCOT specific advice, the Royal College of OT specific advice. And we aim to reduce the pressure of services by allowing patients to access early intervention to maximise their health outcomes. We innovate and welcome change, embracing improvements to build sustainable, fit for the future care. So this is our universal tier. So we took a lot of time creating this, but we've got three elements to it. So our online resources are on our website, and these can be accessed by anybody. The QR code on the left, that takes you to our web page, and if you scroll right down to the bottom, there's a section in pink, and it says universal information, and that's where you can find lots of advice sheets, strategies, activities to practice. Anyone can access these. It's not just specific to our locality. We're not precious about it. So please feel free to have a look at them and use them as you wish. So resources can be used for individual children or for whole classes or groups of children, and it allows for intervention to start straight away. So rather than children having to go on a waiting list to see an OT, this is accessible now, and they can get cracking on it, and they can get that support straight away. Alongside our online resources as part of our universal tier, we also have an OT advice line. So this is for within our service, so our central Cheshire service. So this is open for anyone to get in touch and speak to an OT. So there will be an OT on the end of that line, and we do it once a week. And this could be parents, education staff, health staff, or even some of the older children themselves that would ring this advice line. It's an opportunity to ask for advice on specific functional areas of difficulty, but also they could be asking how to navigate the website or about our referral process, or just to discuss some of the advice and how to implement that for a particular child or with a group of children. We initially just had this advice telephone line, and as I say, we do it weekly, but we had a 2-hour window over lunch and early afternoon, thinking that would be the best time to make it accessible. And then on review, we really felt that there were still some difficulties, particularly for Senkos and how busy that was in their daily timetable to access during that time slot. So we set up an advice line email. So now we still manage that during our advice line times, but anyone can obviously make contact when it suits them. Within the universal tier, we also have a link person role. So this aims to improve accessibility and support settings with universal advice without a referral being made. So this could be early years settings, primary settings. And it's about being proactive and sharing that knowledge with settings so that children get the support they need as soon as possible. And then hopefully they wouldn't then need an ongoing referral to OT. And more recently, it's been the therapy assistants that have been tending to take on this link person role. They've got good links with these settings already. They're going in regularly. So, and they've met with groups of education staff in certain schools, or they've met with individual staff such as teaching assistants. And they go through our website resources and just have more informal conversations about universal strategies and recommendations. So this is an example of the universal information on our website. So this bit on the left is the pink bit that I was saying earlier. And it's broken down into foundation skills and activities of daily living, which the activities of daily living is more about a functional skill difficulty. So activities of daily living is very much an OT phrase, but it means function or occupation, which is where the occupational therapy name comes from. So on the right-hand side of this, it shows the foundation skills content. And these are really a variety of skills which contribute to the overall functional skill of a child. So each one of these links, these blue links at the top, takes you to further information on each section, which is the multicolored bit below. And then within these, there's then different advice sheets and activity ideas to practice to develop skills for these children. We do have a sensory processing section on our website, which is at universal level. However, our trust does have a specific sensory processing OT team. So for anything targeted and specialist, we would signpost to them. But we've got general universal advice here so that it's accessible. So this is the example of the activities of daily living section on our website. So this includes things typically seen within schools, such as handwriting, organisation, posture, and it also includes things typically seen within the home environment, such as using cutlery, dressing skills, self-care. And again, just click on the blue boxes to access the resources on each topic. This is an example of one of our universal resource sheets. So this one's under the foundation skills, specifically fine motor skills, and it looks at the importance of hand and finger strength in fine motor activities and gives activity ideas to improve hand and finger strength. So yeah, the bit at the top is about the general importance and what we need hand and finger strength for, and then the bit at the bottom is activities to practice. And children will pick ones that they prefer, or have a bit of a mix and match of each one. This is another example of our universal resources. So this one is on the functional skill of handwriting, and an aspect of handwriting called fluency. So this is just an example. There's lots. This actual bit advice on handwriting is a much bulkier document, but just for purposes today, this is just an example. So you can see on the left-hand side, it includes strategies. And then on the right-hand side, it's activities to practice that will develop skills, specifically on fluency in this case. So universal advice and activities can be embedded into settings as standard practice, and this will be helpful for all children. So this could be about adding hand warm-up exercises into a whole class routine. It's something we really encourage a lot, this one. So especially prior to periods of handwriting within lessons. And it just means that all children are doing it. The children that specifically need it don't feel like they've been highlighted. It's just an activity that the whole class do, and it is very much helpful for all children prior to periods of handwriting. Another idea would be using the fine motor activities to complete in group settings, or in early years. Quite often, a lot of early year settings have workstations where they would have some of these fine motor activities set up within the room. The advice could be embedded in terms of using graded activity to support differentiation in PE, for example. So maybe within catching skills, it would be varying the object caught, the size of the ball, the distance, etc. So that universal advice could be used within every PE lesson, for example. And this is all within the universal tier. So our targeted tier is our next tier, and this is for children that just need a bit more support. So they're still struggling to develop skills, and they need more targeted input over and above that of their peers. And for this aspect of our service, we do need a referral. So we accept referrals from health professionals and school SENCOs, but we really prefer this to come from school, because these are the adults that are working with children and they really know them best. Prior to our service changes and going to this tiered service model, most referrals came from GPs, and they obviously don't know the children's functional needs as well as school. So we opened up the referrals to SENCO to get better pictures, what's been tried, what isn't working so well, what has been working. And this has really helped with the triage of our referrals, but it's also helped join up working with schools that we work alongside. In order to access the targeted tier, the universal tier must have been accessed first. We can't just come straight to the universal tier. So if we do get referrals direct, we will signpost people to the universal information first. And we say that this universal tier should have been accessed for about a term, so about 12 weeks, to really give it a chance to develop skills with children. We also ask for a diary sheet of the universal input to be included and sent alongside the referral so that it can be triaged. And it might be that there's lots of areas of difficulty. So we have quite a few diaries, and we ask for diaries for things related to school to be completed by school, and diaries for things related to home to be completed by parents. So we might get a bit of a mix of the diary sheets coming through. This is a picture of the diary sheet. So the qualitative data on the bottom sheets at the bottom of this, you can see it really helps us to understand the reason for the referral, and it helps us to triage it. So it allows us to gauge whether the referrer really understands and the remit of OT, and to avoid any inappropriate referrals, which we were getting previously. So this qualitative data is really important, and it allows us to see that the universal information has been accessed as well, and that the aim is on improving function rather than just purely going towards a diagnosis. So what to expect after the referral? The targeted aspect of our service involves further information gathering in the form of an online parental questionnaire. So this looks in more detail about what areas of concern are for the family and the impact of these difficulties. And it gathers a picture of the child's developmental history. The telephone appointment is then held between an OT and the parents or the carers to discuss the questionnaire and offer more targeted input based on the concerns raised. This is often a really lengthy telephone call. It can be up to an hour, but it's an opportunity to really understand the impact of the functional difficulties within all aspects of the child's life and to discuss priorities for the individual families. Each child and each family will have their own priorities, and it's not for us to say what they should be. So this is a really good opportunity to understand what's important to them. Following this telephone appointment, it might be that no further OT input is required, and parents might feel that after that advice, direct contact with the OT, they feel that their concerns have been addressed. But if not, that's when we would offer a further in-person assessment. And this is what forms our specialist tier. So this occurs in a clinic setting, and it's often an hour long, sometimes a little bit more if the child can tolerate it. And it looks at the particular areas of concern discussed in the telephone appointment at the targeted stage. And the OT will assess the functional skills within the clinic setting, but it will also, or usually involves a standardized assessment. So we frequently use the movement assessment battery for children, which looks at motor skill deficits. And then the outcome of this standardised assessment would inform the OTs as to whether to refer to community paediatrics with a view to consider a possible diagnosis of developmental coordination disorder, or dyspraxia as it's often called. Within this specialist here, we would complete reports, the OTs would complete reports, and depending on need, they may be offered specific treatment, or it might be that they just have the specialist advice at that point and they're discharged. But the specific treatment options are based on individual goals. So treatment might be at home, it might be in clinics, or it might be at school, and it may involve a block of sessions with a therapy assistant to work on a specific area of skill. It may involve the OT creating a programme and upskilling education staff or upskilling parents in how best to support that child. OTs would then usually offer an appointment to review goals in sort of 3 to 6 months later. And at that time, some children will have met their goals and no further treatment is required, but other children may have new goals which need more specific OT input at that specialist level. And then it then gets repeated. They set the goals, they may have a block of treatment, etc., and then they get reviewed. So this slide just shows how we measure the outcomes as a service. So those children accessing our specialist here will have GAS goals, and these are SMART goals which have been discussed between the child, the parent and the therapist. And the aim is to ensure that the goals are meaningful to the child rather than just a tick box exercise. And this is what I was referring to earlier. It's not for us to say what should be important for that child and that family at that time. We use GAS goals as an outcome measure for this aspect. For the universal tier of our service, we've got less of a structured way of measuring outcomes. And so this is something we're looking at improving to enable us to demonstrate the effectiveness of the service. But currently, we do record the outcomes of the advice line uptake, and we record feedback from parents and professionals who access it. And it's provided quality feedback, which really helps us inform us on where to develop going forwards. We've received some really good feedback from this so far, with callers to the advice line feeling more informed and better equipped to meet the needs of the children. And callers to the advice line are really grateful for a chance to speak to an OT. You will get an OT on the other end of that phone when you ring it, when it's open. And it's a good, they really appreciate being signposted to things within our service, but also actually if it's not within the OT remit or not within the remit of our service, we do signpost them to other areas as well, and we get good feedback on that aspect. One huge outcome for our service so far, or probably the biggest outcome, has been our waiting times. So our waiting list have dramatically reduced. We currently have a waiting time for targeted input at under 6 weeks, which is much less than it was almost, it was almost a year before we changed this. So it's really enabled the service to shift from a firefighting and reacting to need to being proactive and having the capacity to really adapt the service to meet the changing needs of the population and the children. So what next? This has been a big project to change the structure of our service, but we're now undergoing a continuous improvement project on what to do next. So reviewing how things have gone so far, what the impact has been, and if there are any areas that we can improve on. We're continuing to collect data on the uptake of the advice line and the email, and we're now looking at the quality of the referrals coming through. And we've got a few change ideas as well. So we're thinking of things like expanding the online resources, increasing the awareness of the link person role, providing training for education staff based on data collection and quality feedback from settings. So I think that will be the big area of where to go next. We're really aware this is a constantly changing project, and we're really excited to see how it might develop in the future. Yeah, just watch this space with it, really. We're all very excited about it. Thank you. I'll just stop sharing a second and see if anyone has any questions.
Thanks, Eve. That was really interesting. I can see there's a couple of questions in the chat, but I'm assuming you have access to those now as well.
I can, yeah. I'll just try and read through. Self-referrals from family. We haven't actually. That's Hannah. No, it's not. Our speech and language therapists, they do accept self-referrals from family, but we've not really found the need to. Is that something that you're finding that there's a need for in your service, or?
Yeah, it was just that we're finding we've got a telephone advice line as well, and we're finding that sometimes we're advising parents that it would be an appropriate referral, and then they go to their GP, who writes a shockingly poor referral, and then it gets declined because the person that's triaging isn't the person that spoke to them on the advice line. And so parents are going round and round, and actually the information that they give is 99.9% of the time better than what the GP would give. And schools can refer. Some schools tell the parent, go to your GP. So it was just whether
we had that similar really at the beginning of it all. When schools we were trying to get that information out there that they could refer to us. So we were having that a bit at the beginning, and schools were still saying go to your GP. And like you say, the referrals, they're not particularly helpful. The GPs don't know the children to the same level. So we find just improving those links with schools has stopped that really. So we will email the schools. We're happy to say to the parents when they ring, just ask school to ring us or get them to drop us an email, or do you want us to send them an email? Obviously, we won't send it specifically about a child, but just, if it's a school that maybe isn't as familiar with our service, we will contact them, a bit more of an outreach thing. So we do find then the quality of the referrals and just that engagement has been a lot better. But yeah, I know what you mean. At first, it wasn't. There was still that grey area, probably for a year, I'd say, where everyone was still a little bit unsure who could refer and what information was needed. Yeah,
we're hopefully moving to link therapists in schools, so that will hopefully help with that. The other question I had was one of the barriers for us to this approach is that the service isn't jointly commissioned. So the local authority do partly commission speech and language therapy, but don't currently partly commission OT. And so we're trying to do it all out of ICB resource. And I just wondered, are you jointly funded?
No, we're not. No, not for OT. No.
Okay, thank you.
Thanks. Why did you decide to use the movement ABC and not the goal of movement? We've always used movement ABC really, and we find that we've never really had any difficulties with it. I know it's what the community paediatricians are keen for us to use in terms of a diagnosis at the end point. So what is it that you're using? Sorry, that's Catherine. No, Catherine, not here. Yeah, so we've always used the movement ABC. This wasn't something that we started at the same time. We've now got the movement ABC 3, which is the online version, and it's going really well. Yeah, I think Hannah might have just answered that as well. Yeah. Oh, sorry, Catherine, microphone's not working. Right, okay. Yeah, no, we ABC 3 or the ABC movement ABC is what the community paediatricians are keen for us to use, and we've been happy with it, so no real need to change. We obviously do the functional assessments alongside that as well, so not every child that comes in will have a movement ABC assessment. It's just the ones where the OT feels like it's needed to progress that referral further to community paediatricians.
There are some people with their hand up as well,
Okay.
Eve. Rachel, you're the first on the screen. Do you want to come up? Rachel Akers, that is, sorry.
Okay, thank you. So I was just wanting to know a little bit more about the link person. So obviously, I'm assuming the fact that you've called it a link person means that it might not necessarily be a therapist. It might be one of your assistants or support practitioners, whatever you call them in your team, because it's very variable, isn't it?
Yeah.
Okay.
Yeah.
And you said at the end that you were looking to see whether you could increase awareness of this. So is that just actually, so it's not covering all schools and settings at the moment, it's just covering, how have you set that up?
Yeah,
because
so
I'm thinking to actually go from 0 to all in one go is potentially a lot of capacity, isn't it? So
so we started off with it's generally the therapy assistants that do this. And some of them have been in the service a long time, so they've already got great links with a lot of early year settings and schools. So we started off with them just being the link person for the ones that they were comfortable in, the ones that they already knew the staff. And then from there, they got the confidence up with, that then they're generally not used to talking to bigger groups of people or to giving that advice without there being an OT with them. So that was quite a change. So we said just start. It was a bit of a soft launch, really. Start doing it with those that you're comfortable with. And they might, quite a lot of the time, they'll go on to like an iPad that's in the class and they'll go through with the teaching assistant what resources are online and things. So they started doing it with the ones that they were already known to, and then as their confidence is built up, that's got bigger. So then they've just started offering it out. So they might send an email to the Senko or to the school and just say, would you like us to come in and have a chat? Which is where sometimes they've gone in and chatted to a group of staff at a staff meeting. Not all therapy assistants are confident to do that, so it does kind of depend on the individual. And we've just kind of kept a record of when that link's been established. So there's some that we probably don't have as good links with yet, but they're on the radar and they're on the list too. But we didn't just start with all, and we started with early years and sort of, really that bit first and then expanded it. But not in a particular order, really, other than that.
You've sort of done a targeted approach to your universal support around particular settings, haven't you?
Yes.
Yeah, sort of. Yeah, okay. No, I just wanted to understand the mechanics of it, because to actually go from nothing to 100% is quite a big jump, isn't it, for that particular staff sort of skill set as well, a group and its capacity, isn't it? So you can soft launch existing schools where there was already relationships. They've built the skills and sort of tested the model, and now you're sort of trying to roll it out.
So we've not got everywhere with it. There are still some where we need to work on that, and that's what I mean by just expanding the awareness of that and getting it out to those ones that maybe don't know our service as well as others.
Okay, but you're leading on that, so you're doing the contacting of the settings rather than the settings coming to you, or a bit of both?
A bit of both. We can talk about it at the advice line if settings ring. We've got the information out there. It's all been sent to them, but generally that's how we do it, because settings are just so busy, aren't they? And they can't remember everything. So it is generally led by us saying this is what we can provide. Yeah.
Thank you.
Amy?
Hi, just a couple of questions from me, if you don't mind. Just while you're talking about link workers, that support that goes into the settings, is that generic support as opposed to around individual children's needs?
Yeah, Yeah, because at that point it's universal. So it might be that that therapy assistant is actually going in to see an individual child that's already under our specialist service. And while they're there, they'll do some of that generic support. But yeah, in terms of it being under the universal, it's not about a child in particular. It's about maybe try this for all of your class, or it might even be simple things like all the children, they're sat on chairs and the legs are dangling and the feet aren't on the floor, and it's, you know, that general advice and activities. So there might be that the teaching assistants will mention a particular child, but at that point we don't have a referral for them. It is just universal at that point.
Okay, that's useful, thanks. And then the other question was, because we're in a similar position where I'm based, and we've been reviewing our OT service, and we are looking at the universal support that we've got available on our website and things. How did the wider system take it when you moved to say they had to have evidence of the universal offer before they could put a referral in? And how did you consult with them about it beforehand?
It's been difficult, and it's been a bit, we had a phased first, so we had again a soft launch for it. So we had about 3 months where we were doing a bit of both just to try and get that idea embedded. I think because we weren't open to Senko referrals prior to this, we just had healthcare referrals. It went, in one respect, it went down quite well, because Senkos were, although they have to do the universal stuff first, they were thinking, well, this is great, we can now refer. So mixed, I'd say, at first, while they were really understanding what we were asking. And you know, a lot of our response to things is we're not a magic wand. Like, this universal stuff, regardless of whether we see them in clinic and then give the advice, or whether we give the advice through the universal tier to start with, that bit still needs to be done, and that bulk of work with that child still needs to be done in their everyday settings. So mixed, I think, is the answer, until sort of relationships have improved and it's become clearer what our service pathway is. Yeah,
and eventually they've gained confidence in the way the new pathways work, and so they've come round in the end. Yeah,
and we've got the advice line, and I think when they ring and you can talk to somebody and explain it, they all go away and think, you know, they say, right, that's so much clearer now, I understand. So we try and plug that advice line. We've had a separate QI project going on just about the advice line and trying to get more people to ring that, which has worked. It's worked really well. So but yeah, that helps. Just, it's those relationships, isn't it?
Yeah, no, that's great, thanks very much for that.
Thank you. Rachel, I think that's, yeah.
Thank you, Eve. Hi. So mine's a follow-on question, really, from Amy's, in terms of the diary sheet that you mentioned that needs to be submitted alongside the referral. Who completes that, and how well is that completed? So
we're currently collecting data on how well that's being completed at the minute, because it is mixed, and to be honest, it's not completed as well as we would like. So if it's a school-based problem, we ask for that to be completed by school. So it's usually the teaching assistants that are working alongside the children. And if it's something that's to do with activities at home, we ask for parents to complete that. It's mixed how we get this. Sometimes we'll get it just from school, and then by the time we get to the parent conversation, the telephone call it targeted, the parents aren't really aware of that. So we're kind of taking a step back so that they can access the universal stuff as well. But yeah, ideally we would have, depending on the area of need, would have a diary sheet completed by school if that's the activities at school, and by parents and carers if it's completed at home. But yeah, it's what we do find is education staff quite often write in there the things that they're already doing with that child as part of their intervention, rather than the things from our universal resources. So there's a lot of going back to them, emails, phone calls, to say, that's really great what you've been doing, but try this, and then come back to us. That takes up a lot of time.
Thank you.
Amy?
Sorry, just on the back of that, just made me think of something else. So that when the diaries go out to parent carers, because obviously we've done a lot of work as well at looking at the responsibilities of parent carers at home and things they can be doing to upskill their children. Have you found that them diaries going home and parents having to complete them, has that helped with some of that?
Sorry, say that again.
So parents' understanding of what their responsibility is at home to support children's skills. Has that helped with some of that? Or?
I don't think so, really.
Okay.
I think more often we get them completed by school rather than parents. It's probably 20% of parents fill them in, which is why by the time we then come through to the targeted and we have the telephone appointment, that's where we really need to explain to the parents the importance of what they're doing at home. And that's when the OT then reiterates all the universal things that, in all honesty, sometimes they didn't even know about because the whole thing's come from school. Yeah.
Okay, thanks.
Everybody, I can't see the rest of the screen. Okay.
Rachel's just come up.
Oh, yeah.
Sorry, yeah. It's just kind of made me think really about how we can involve parents more in these discussions, because I'm a commissioner by background, and the feedback we get from our therapist team is that, as you've mentioned, parents are looking for a magic answer, aren't they? They kind of want a magic solution. They want it right now, and they want it really quick, and they want it to work overnight.
Yeah.
But how can we then help them understand that there is all of this, because there's so much information available to parents, and I think sometimes it can be really overwhelming for them. They don't know where to start. So I suppose, how do you then encourage parents to use all of that universal information before they even think about making a referral or speaking to the Senko or another healthcare professional?
That's where we would want them to ring our advice line. So at that point, we would talk about what's important to them at that point. So it wouldn't be specific for the child in terms of we're not going into too much detail about that when they ring the advice line. But when they come with a big picture of the child and all these difficulties that they're struggling with, and we'll say, right, well, what's the most important thing? This is the thing to do first, then look at this. So it's very much the conversation at the advice line point where we can say, right, this is your priority, work on that first, and then come back to us.
Thank you.
Hannah's, what times are the advice line? So we have 12 till 2 on a Wednesday during term time. And we kind of did 12 till 2, thinking it was over lunchtime, and there might be a bit more availability for people, for parents in work, or for Senkos to be ringing and things. But I think the feedback is just the school day is just hectic, and there's no chance of us being able to ring during the day, which is where we set the email up. We do get Senkos ring, but the others that can't ring just say, I don't have time during that day.
Thanks for answering all of. Yeah, it seems like some really good questions though. So thank you everyone for engaging in that, and thank you for all your answers, Eve. That was really interesting. I thought I would just sneak one in at the end if that's all right.
Yeah.
when you've been kind of doing the kind of gradual rollout with the link workers we were talking about earlier, I was just wondering, has there been any kind of like training needs that you've identified? Anything that's kind of come up as things you've had to put in place for practitioners?
With our therapy assistants, do you mean?
Yes. Yeah, exactly.
So we're quite lucky. We've got quite a lot of historical band 4 therapy assistants, and we've found that they're very experienced in this. They've kind of the issue, that the barrier they've had is just their confidence, but actually their knowledge has been there. We've got a few band 3s, which is quite a new role within the community for a therapy assistant. So they're doing shadowing with the band 4s, and they'll quite often go out with the band 4s to do this link person role. But yeah, they currently then they are just starting to do it on their own now. But it's more shadowing the band 4s, because the band 4s have been here for years and years.
Great.
Yeah.
Thank you. If there's no other questions, we can probably bring this workshop to a close. But thank you really so much, Eve. That was really, really interesting. And I think the level of questions shows how engaged everyone was. Just to flag now for everyone's benefit, we'll have almost a 20-minute break. Very exciting. You can rejoin your second workshop at 12:15. And that will be the final one of the day. So everyone should have a link to the second session. Should be different to this one unless you're really, really keen to learn more about Eve's work. But if you haven't got that, if you could just email rise@ncb.org.uk, I can write that in the chat before we leave as well. But yeah, feel free to go off, have a cup of tea, and rejoin your second session at 12:15.
Thank you.
Thank you.
Thanks, everyone.